All right. And man, breast, uh, this is a double D chapter for sure. This is huge. The There's a lot more on this chapter, and so when it comes, I think when it gets to, and you know how I love when I get to the part in any chapter, all of our chapters, which just starts listing off diseases or listing off different tumors. I think when we get to that, we're pretty much going to go through, you know, here's a well, the more common tumors we'll talk about, the more uncommon tumors I don't think we're going to spend a lot of time on. We're just going to kind of hit it, show you an image of it, tell you basically what it is, and then move on to the next one. So I think it'll be a bit fast, but that's what the book is for, is to go back and really reread that stuff. So, because otherwise we're going to spend another 3 days on the breast, and I don't think we could afford that time. But today I have a number of pictures and an outline for us to talk about. The big thing I really want to talk about is the BI-RADS breast imaging, reporting, and data systems. And that's what radiologists use to really stage and report, and it's a language that all radiologists understand. Everyone agrees to the language, and so when this patient goes to another doctor, or another doctor is reading a follow-up study, they're able to look at the BI-RADS report and understand exactly what the original doctor was talking about when they made that report. Just because it's on the screen, let me just quickly talk about, because we'll kind of go back and forth. We'll look at some of these images on the side here. Let's just quickly start about STAR is the acronym for smooth, and this is, well, I should probably write this down. Simple cysts. I need a smaller pen. Okay. Simple cysts. They are smooth in thin walls. So the walls are not bumpy and thick. There's nothing growing on them. They are smooth. There is through transmission on a simple cyst. They are anechoic, not hypoechoic, not agogenic for sure, anechoic. And they are round or oval. And then the very first image I have breaks one of these rules. It is thin walled. You don't really see much of a wall at all. It just goes from cyst to tissue. Through transmission. Yeah, you're definitely seeing through transmission on the second image. These are both the same cyst, believe it or not. It's just that the more round one is probably caught at right about that level or so. These are definitely anechoic. There is nothing in there, no septations, no mural wall projections, nothing floating around. And they're kind of, I mean, this one's round, but like I said, this is the same cyst. So simple cyst, even though it violates the round, most RADs would probably call this simple. So there is a bit of a violation, and if the radiologist wants to call this a non-simple cyst because of well, this area here, then that is he or she's prerogative for sure, because it's not really, doesn't follow the round or oval very well. Okay. You know what? I'll just talk about, damn it. I will talk about these two, and then we'll go to the BI-RADS. Benign appearing, in quotes, is for this case, it is a cyst. It is not completely simple. You see, there's little things floating around in this cyst. So it's not 100% simple, but it's still benign. I mean, no one's going to look at this and say, "Oh gosh, there's something going on there." So, not worrisome, but not simple either. And so this is more of a what's the word for words? What's the word for? I'll just call it jargon. It's kind of the jargon for that radiologists can use. Benign appearing, even though it's not simple, it still looks benign. Because you don't want the ordering physician to say, "Oh my gosh, there's a complex cyst in the breast. We should be and then the doctor's saying, "Yeah, it's technically complex, but look, it's nothing." And so the ordering physician doesn't have a flip, doesn't freak out. And this one just shows a little color Doppler. And this another thing about simple cysts, and not in the star designation, but another thing you could always look at. There's no internal Doppler or vascularity, so that's very important. If there's anything internal, then it's certainly not simple. In fact, it's very concerning if there's internal, like Doppler going through there like that. And minimal to minimal Doppler on the periphery. Minimal Doppler. So this person just had one little spot of Doppler there. So this is not a concern at all. If there was Doppler surrounding it and like increased hyperemia surrounding it, that would be a bit of a concern. Okay, BI-RADS. Breast Imaging Reporting and Data Systems, or data systems if you prefer. All right. So it goes from 0 through 6. 4 has several subcategories, but 0 is an incomplete. In other words, the doctor doesn't have enough information. He or she is just not satisfied with your exam, the mammogram exam, or the mammogram shows something, and why even write a report yet? Let's just send them straight to ultrasound, then I'll write the report. So the temporary report kind of would be a 0, and then once they got the ultrasound results back, then it would be sorry, it's got a little messy. And then once they get all the information, then they'll write their full report and then give it a 1 through 6 at that point. So incomplete is not bad, but it's not good either. It just is incomplete. So BI-RADS 1, negative. And of course, in the medical world, negative is always good. Negative. So no further actions. No further actions. No follow-up ultrasounds. No fine needle aspirations. Nothing. BI-RADS 2 is benign. Oh, you know what? Let me go back to negative. I wasn't really, I was kind of getting 1 and 2 mixed up in my head. Negative is not only no further actions, but nothing seen. So it could, you had your mammogram, you had your ultrasound, and nothing at all is seen. Hence, no further action. Just come back and whatever your schedule is. Benign could be like a cyst, adenoma, things that we see all the time, etc. Once again, no further action needed, because we know it's a simple cyst. We know it's an adenoma. Women get adenomas all the time. It's just so obvious on the screen that we don't need to do a follow-up or anything. Number 3 is probably benign. Probably benign. So let's how about this? Question mark. Septated cyst, or something that's maybe a cystic lesion that's a not quite, it's not a simple cyst. I could have just wrote that in there, non-simple cyst, rather than septated. And in thin septated. Oh, let's do something here. Thinly septated cyst, because thin septations are probably benign. However, follow-up is required or requested, and that could be like 6 months. Come back in, get that looked at again, see if it's changed at all. And if it's identical, then we'll probably reduce it down to a number 2. 6 month, or maybe maybe a fine needle aspiration. Then we get into the ones you don't want. Suspicious. Oh no, that was right. Suspicious. 4A, low suspicion. 4B, intermediate suspicion. And 4C, moderate. So let's say like a low suspicion. I don't know. Let's say like a hemorrhagic cyst, but you don't really know if it's a hemorrhagic cyst or is it cancer, or so. But you're pretty sure it's hemorrhagic, so it's suspicious but low. Let's follow up, or maybe do an FNA. Intermediate might be, let's say, well, I keep picking on cysts. Maybe there's solid tumors too. Let's say it's a tumor that looks like an adenoma, but it's the wrong shape for an adenoma. So, I'm a little concerned about that. Adenomas don't usually look like that shape. And then moderate might be, well, it kind of looks like an adenoma, but boy, look at the shadowing behind it. Remember, I don't like shadowing in the breast at all. 5, this would be highly suggestive. And that would be like a greater than 95% chance. And sometimes, unlike, let's say the thyroid, we basically never know if we're looking at cancer or not in the thyroid. It's usually not, but we don't really know, because it just doesn't, it all looks the same. breast is different. Sometimes it looks benign and it's not, but if it looks like cancer, it probably is cancer, both in mammography and in ultrasound. Doctors kind of have a pretty good idea just by looking at the pictures. And then number 6 is known. So in other words, they've probably already had an FNA. They know it's cancer, and now they're doing a follow-up imaging, for whatever reason, maybe for placement of a needle or something, but it's known biopsy proven. So 0 incomplete, not bad, not good, just not complete. 1 negative, absolutely negative. It's a simple cyst. Obviously it's an adenoma, or just let the patient go. God dang it, I did it again. Negative, nothing seen. Nothing's, oh, damn it, and I crossed it out. Nothing seen. Okay. Darn it, now I gotta get my color back. No, it's a different color. There we go. All right, 2 is benign, simple cyst, adenoma. 3, probably benign. Not so simple cyst, but probably benign. Suspicious, now we're starting to get some other things that we start to look at. And most of those things are down lower on the list here. We'll talk about. Highly suggestive, basically they know it. They take one look at it and say, oh yeah, that's cancer. And then 6 is biopsy proven. Okay, so I was going to do, when we do find masses, and are these all solid? I guess this counts for cystic and solid. I think of this as mostly solid, but cysts are in there too. The shape of a mass, round or oval. In fact, we have oval, round. These are both good things. Irregular, guess what? Not good. We get a little more concerned with irregular masses. Doesn't mean it is, just kind of points us in a certain direction. The margin, in other words, the exterior of the mass, around the outside of the mass, circumscribed. That basically means you see a nice, clear delineation between the tumor, or whatever kind of tumor it is, and the breast tissue on the outside, nice and circumscribed. Nice, basically a nice wall. And then there's not circumscribed, and that's kind of, we've got some, once again, indistinct. Now, why did we, irregular. Shape is irregular, margin is indistinct. Yeah, okay. Yep, that's right, that is correct. Indistinct, in other words, let's draw myself another mass here, except this time, just because I can and I feel like it, distinction goes away. Where exactly does it end? Does it end here? Does it end there? Does it end there? We're not sure. So it's an indistinct margin. Oh, and forgot my here, I'll put them over here. Smiley face. All of these are generally not as good. Let's see, angular. It's kind of a weird term for a mass. We don't usually see angles, but that could be an angular type shape. Not to mention irregular. Microlobulated. Okay. Microlobulated means that has these small lobulations. So micro, I'm going to add a little micro, well, I might as well just sad faces all around here. What's the next one? Oh, that's a really sad one. That one's got a tear on it. But if microlobulated is bad, macrolobulations are okay. They're not great, but they're okay. A macrolobulation is more, well, larger lobulations, macrolobulations versus microlobulations over here. And this one with the tear even, that's how bad it is spiculated. This is really bad. This is when you see, let's draw, I'm going to draw my irregular, angular, and then I'm also going to draw little extensions. You may or may not, well, if you don't see them, then you can't report them, but these little extensions. And this is really, remember when I said if the skin has an unnatural retraction or dimple in it, or if the nipple has recently turned inside out, retracted, the tumor is reaching, it's growing out in all directions, and it's reaching out with these little fingers, and it's pulling on everything. And that's why when it's spiculated like this, it's a very bad sign. But that's also why cancer doesn't move. So when you're doing a self-exam on the breast and you feel a lump, and trust me, that is an everyday experience, especially when you're younger and you have fibroglandular breasts. If everything seems to move when you're pushing on that lump, it seems to slide away from your finger. Obviously not, from one side of the breast to the other, but it slides underneath your finger. That's generally a good sign. If it feels like really stiff and it doesn't move, that's a bad sign. And it's all connected. Where's my, okay. These spiculations, are really what's causing that. They're reaching out and grabbing all the tissue and locking it in place. So circumscribed, pretty, whether solid or not. Well, if it's a cyst, obviously it's a simple cyst. But if it's on a solid tumor that's well circumscribed, good sign. Not circumscribed, indistinct, bad sign, because what's going on? Well, basically cells are, cancer cells are growing out, and so you can't see a distinct wall. Angular and spiculated, I would say, are related. Microlobulations, why is it microlobulations? Really, it's because it's uneven growth. And like, you know, these cells are growing out slightly faster than these cells, and it creates these microlobulations. Whereas the macrolobulations are just, they've just found to be better overall. They're not as concerning. So it looks like a puffy cloud, it's okay. And then spiculations. Okay. Posterior enhancement or yeah, okay, yeah. The book kind of puts some other things in here that really aren't enhancements. So I'd say posterior enhancement or lack of enhancement or whatever. But well, you could have none. And let's see, none. That's generally good. Enhancement. That's a good thing. Obviously, behind a cyst, you're going to get enhancement. And behind a cancerous cyst, you're going to get enhancement. So enhancement's not always good. Shadowing, that tends to be bad. So like I said, when you come across a shadow, find out what's causing it. If it's just Cooper's ligaments, also previous surgeries can cause shadows, a little scarring in there. So know what the patient's history is. Shadowing though behind a apparent spiculated hypoechoic tumor is generally a bad sign. Let's see, posterior enhancement. What else do I have there? Oh, and combined. Combined. So you have some enhancement, some shadowing. In other words, you probably have some solid, some cystic. And you know what? I don't even know what to say about that. That's just, oh, his eyes are too far apart here. Okay. That's just nothing. You know, that's a nothing burger. It's certainly not as good as enhancement, but it's not as bad as distinct shadowing. So calcifications. I was gonna do a little more work on this one. Oh, and this is kind of my own. If you're following along in the book on page, by the way, this is like 468. It's a table, big table, 467, 468. Calcifications. Oh, I really only have. I only have two. Calcs outside. Calcs outside neoplasm. That's okay. Women have breast calcifications. Oh. Women have breast calcifications, and typically larger calcifications are better than smaller calcifications. Now, clusters, like on mammogram, sometimes they'll find a cluster. That's generally a bad thing. So you don't want to see clusters on mammogram, and even if they don't see the actual tumor, they'll be like, I don't like that. But outside of a neoplasm, and you know what, no, I don't want to say anything the book didn't say because then I'll be wrong. I guess I can keep this one because calcifications outside. All right, your book didn't really say it this way, but I'm going to say a little bit different. Calcs inside neoplasm. Why do I keep putting an L or an S in there? How about this? Especially micro calcs, generally bad. And then there's intraductal. And I'll be honest with you guys. I'm putting a neutral face on this one because I can't remember, and I haven't read that far yet to see. I can't remember if intraductal calcs are a really bad sign or just a sign. But we'll find out. We'll get to that at another point. Orientation. This is a good one too. Orientation, not sexual orientation of the mass. Let's see. Wider than tall, as in you're looking at the mass and it's more or less shaped like that. Good. We like to see wider than tall. Taller than wide. Bad. Just remember, most of these they're pointing us in a direction. Most of these are not, other than like spiculated, which is just pretty much a guarantee, but the most of these are just pointing you in a direction of good or bad, not for sure. Echo patterns, I'm not going to put a face on some of these because some of it just is what it is. Okay, anechoic. Oh my God, echoic. I'm losing my mind. If we're talking about a solid, that's not good. If we're talking about a cyst, of course, that is good. So that one's kind of a double whammy on that. And let's see, hyperechoic. I'm not going to put a face down for that one. And generally, I don't get too concerned about hyperechoic, but I might be incorrect on that. So I'm not going to say. Complex cystic solid. Ooh, let's see. Complex cystic solid. Pretty much complex is generally, no matter where you are in the body, it's better to be simple than complex when it comes to neoplasms. Hypoechoic. I'm going to go ahead and put a sad face next to hypoechoic. That's generally not good. Isoechoic. I'm going to go ahead and put a, I don't care. Like I don't have an opinion face on isoechoic. A lot of times adenomas, which we see all the time, are pretty much isoechoic. So those are fine. And then heterogeneous, well, that kind of goes with complex cystic solid. Well, it's heterogeneous. We're assuming that's a solid. And that tends to be bad news. Points us in that direction anyway. Associated features. Well, we've kind of mentioned this first one. This is a archetypal architectural distortion. Architectural distortion. Well, I've never mentioned architectural distortion, but what I have mentioned is that the mass cancer pulls on surrounding tissue. It pulls on Cooper's ligaments. It also, let's see, I'm going to do another. Here we'll do dash pulls dash. Oh gosh, what's the best way of saying it? It invades. Invades or crosses boundaries. Crosses boundaries. In other words, if you do have like a Cooper's ligament there, and you have a tumor that's crossing over that boundary, that's a very bad sign. It's also, at the same time, it's probably pulling on that boundary. So pulling in, making dimples on the skin, making architectural distortions in both ultrasound and in mammogram. You could see these distortions. Sometimes you can't even see the stupid cancer because it's small and it's isoechoic and it's the same. It's just isoechoic. You don't see anything, but you see this distortion. Of course, that distortion, it could just be a scar from previous surgery or a car accident, and you had a little bit of bleeding inside the breast and left a scar tissue behind. So it could be that too. But generally, architectural distortion is a bad thing. Duct changes, that doesn't even really. Duct changes. Well, you know what? I'm going to put a neutral face on that one because that could just be hormonal changes. That could be age changes. It could be cancer. It could be, you know, so there's a number of things that causes duct changes, and we're not really getting, I guess we're not really getting to it on this list right now, so that's fine. Oh, skin changes. We've mentioned these already, but on ultrasound, we can see thickening, retractions. So, you know, the cancer's pulling on Cooper's ligaments, pulling on the skin. Retractions. Let's see, how do I have this? I'm going to do a little, I'm not sure your book mentions it, and I was really surprised. Oh, and I mentioned this the other day. I just hope I'm spelling it right. That's here, this is visual. In other words, you're going to see this with your own eyes, the peel de orange, and that's the peel or the skin of the orange. Oh, orange peel. Yeah. Never thought about that. So it's okay. And that's actually associated with this next one here. Edema, is it associated? It is edema. Yeah, it's associated. Because you could have edema, whether it's a mastitis, some cancers, but the pupille d'orange is definitely a indication of cancer. And that was, I know I mentioned this the other day, but let me, um, well, as the breast becomes edematous, the skin gets thicker, but every single little hair follicle holds back, and so the skin gets thicker around the follicle, kind of creating a very dimpled look. And the color, there's color changes as well. Let's see, edema. What's next on my list? Vascularity. Okay, well, okay, so vascularity. What do we worry about with vascularity? Absent? That generally is good. Cancer doesn't grow without neovascularity, so that's a good thing. Internal, bad. So now I'm not talking about like one tiny little big piece of internal flow inside of an adenoma. That's not what I'm talking about. Really more of you could clearly see there's internal flow. That's more concerning. And then around the rim, or let's say, well, I think the book said rim, but I'm going to say peripheral. And well, I'm going to give a neutral face on that one because, you know, at really hyperemic around the outside, that's suspicious for sure. But if it's, you know, a little bit around the outside, that's probably okay. But certainly if it's a rim around the outside and then you see it dive internally, then that's, you know, it's a double whammy. That's bad. Oh boy. And okay, yeah, we just got a little bit left and then we'll go to the, oh, that's right. We have a short day today. Short day. Not short for you, short for me. Elasticity exams. Remember from physics where we look at the shear wave. Let's see. Shear waves. And those shear waves are going off and, you know, perpendicular to the sound beam, which is going this direction, and you know, the sound beam's doing that, shear waves are going off. And we look at we look at the waves, the shear waves in the speckle pattern. And the computer is actually able to get an idea of the stiffness. So that's, remember that. Stiffness. I used to have patients, I haven't told you. Let me finish this up and then I'll tell you what I used to have patients do. Because I was doing ultrasounds before elasticity, so we had to do something different. Let's see, soft, generally good. Intermediate, I'm not going to put a face on that, but hard or stiff, generally a bad thing. Oh, and I was going to tell you what I used to do. I used to have patients hum. And some were too embarrassed to hum, so I just had them state their name, and that's all that happened. All I needed to. I might have told you this I might have told you this when we were talking about this, but basically by humming, I was creating shear by them humming, they were creating shear waves in their body, and I was able to put color Doppler on, and if I had it at just the right setting, I could actually see a difference between a tumor and non-tumor. The problem, and that was called with an F. Fremitis, yeah, that's when you have the patient hum and you put color Doppler down, and you could actually see a difference between the tumor and non-tumor, but it was not very accurate. Not very accurate at all. So what we have today is far better. So if you're following along in the book, I skipped special cases heading, special cases in that. Why did I skip that? I think it was just special cases. Oh. Simple cyst, clustered microcyst, complicated cyst, mass on skin, in skin, foreign body, lymph nodes, vascular abnormalities, post-surgical fluid collection, fat necrosis. Yeah, because we're covering all of that separately, and those are findings. Those aren't. Well, those are. I mean, those are actually more like actual objects or actual lesions that you find. Whereas this whole list, the rest of this list is really kind of talking about, well, the good and the bad, how you describe what you see, whether it's good or bad. It looks like I put myself a little note here. I forgot about that. Also consider, is the mass soft or hard? Now this is really, where did my pen go? There we go. These are both palpated. Whether you do the palpation, the doctor, the patient, you need to know, or you want to know, well, geez, does it feel soft or hard? Does it feel mobile or fixed? And you can go ahead and you put that in your report, your worksheet anyway. Especially if you're the one doing, if your patient reports that I feel a hard lump and in their left breast, you write that down. Patient reports hard lump in left breast, because the reading radiologist might not have that information, so it's important to write that down, because it might not have come across from the script, the prescription for the exam in the first place. Or if you palpate it and you feel something that feels hard and non-mobile, then go ahead and put that in the in your report. And don't worry, your reports are they are a part of the record, but it's also, they usually say right at the bottom, this is a technologist impression. It's kind of a legal way of saying, I'm just a tech, don't kill the messenger. I've got a great video on, and so hard to find decent videos on mammogram interpretations, and especially how to, not so much how to interpret what this mass is. That's a doctor's job anyway, but really how to interpret where this is on the breast. Doctors are pretty much always going to tell you that information, but it's still good for you to have an idea of how it all works. So we have a video on that, which I'd like to watch together, but not today. Anyway, this is going to be the right breast, because they always put the right facing. Like if they had both breasts, the left would actually be put up. Oh, the poor left breast, so malformed. They would actually put it up on that side. So this should be right breast. And we have here a cyst. In fact, a simple cyst. Now, the doctors, in fact, I have some, let's make sure I continue to follow my notes, right? Oh, that's all my biograms. Okay, looks like I'm just missing a page. That's okay. I've got this on on mammogram. I can't possibly be missing this page. There it is. I saw the top of the page and I got confused. Okay. So and once again, for the fourth time, on mammograms, a simple cyst, doctors, they know it. Uh, doctors know when they see that that's a cyst, a simple cyst, but they don't 100% know. X-ray, especially on soft tissue X-ray, it's good at seeing things. It's not always so good at seeing what those things are made of. And it just turns out that fluid turns out to be pretty dense. And it's and sometimes this is a relatively probably older patient. We don't see a lot of fibro cystic pieces in here, the actual gland. You don't see a lot of glandular tissue here. But on a younger woman, the glandular tissue and this guy right here, they're all kind of the same color on the screen, so they could be hard. So, even though they know this is a cyst, they'll probably send this to ultrasound just to double check. But that's a simple cyst. And also, one thing that delineates it from a simple cyst is, look at that little, whoops, my pen is giant all of a sudden. In any case, look at this rim around there. We would call it slightly hypoechoic. That's not what they call it because they're not using echoes. But there's a, they call it radiolucent rim around the outside. That's a good indicator that this is it's a simple cyst and a very thin, definite wall. Sorry, I'm thinking of several things at once. By the way, I don't know. I assume that is a calcification. Didn't even mention it in the article I read. Article I stole this from. I didn't read it actually, but I assume that's just a calcification right there, and of no concern at all to the doctor. Maybe a BB. No, it's not a BB. Look at the inside of this cyst here. See all this structure? You notice how it's continuous with the outside structure? Remember, when we look at an X-ray, and this is kind of a little bit of an aside, but it's an important aside. X-ray is the whole thing. An X-ray doesn't look at even though this looks like a slice, right? This looks like a two-dimensional slice. It's not. It is the three-dimensional breast on a two-dimensional plane. So when we're looking at this, first of all, this is a let's say a 90 degrees. The breast was squeezed 90 degrees from medial lateral. 90 degrees doesn't make any sense. It's just medial lateral. We don't know if this cyst is medial or lateral. We know where it is because the nipple is right about here. We don't need that line. We know it's on the top part of the breast, but it could be anywhere from 2 o'clock all the way across to 10 o'clock. Could be anywhere in that breast in there because we're seeing the entire breast and everything in it. We're not seeing a slice. Ultrasound, And even as an ultrasound tech, you don't always think of it this way. We see a slice. So when we have a two-dimensional image on our screen, well, that's actually pretty accurate. It is 2 dimensions that we're looking at. We're seeing a thin slice. That slice might have some thickness, but that's it. So whatever we're seeing in that is all that there is to see in that plane. Now, let's see, we see a slice or a plane. And I think that's important to know the difference there. Because like I said, X-ray, we don't from one image, we don't know where this is. All we know, it's in the top half of the breast. It could be beyond that, we don't know. Upper outer, upper inner. Okay. I've said my piece. Let's keep moving. Simple cyst. Doctors know it's a simple cyst, but they're still going to send it our way. We've already looked at some other. Well, wasn't quite simple, but oh no. This one is simple. I mean, yeah. There's something there. There's something. Almost perfectly simple, but and that's going to depend on your radiologist whether or not they call it simple or not. I would call it simple, but I'm not a doctor, so from what I hear, I can't do that. 3 o'clock. We'll just go through these pictures and then we'll be done. Oh my God, Kurt, what is this? These would have been helpful. Yeah, fibrocystic change. It used to be called fibrocystic disease, but it's not really a disease, so they drop disease and just call it change. And this is generally late. Yeah, generally late reproductive life. So they haven't reached menopause yet, but their estrogen's kind of a little bit out of control here. So they go through, women go through fibrocystic changes, and it's like 50% of women. So this is not uncommon at all. Let's see, hormonal changes in late reproductive life, hyperplasia of glandular tissue, fibrosis of stroma, cyst formation. Okay, so cyst formation, well, certainly down here, in these 2 images down here, we have microcysts, and those are actually increased acini. The acini have increased in size. They've become fluid filled. Let's see how much do we have. You know what? It's 3 o'clock. We're usually done by now. Let's start there tomorrow. Sound like a plan? Yeah, and actually I'll get a whole other thing going for tomorrow. So, all right. Any